Today we are talking about well-women concept and its application in family medicine and in not only family medicine, anywhere in medical practice. As a practicing doctor, you need to know certain things about women's health care that are applicable throughout their lifespan. And the well-women concept is actually a concept which takes into account changes of women's health over the time from their birth to their death, and addresses and helps them to achieve their full health potential. So women's health over the time period changes. Now they are from their birth, their growth, their cognitive development, those things are under the influence of their environment, their social context, and then once they grow up to the age of menarche, their growth, physical, psychological, dental developments, they changes, and then when they start reproducing at the childbirth, pregnancy outcomes, then other gynecological healthy issues, they all changes over the time. And then once they reach menopause, they will develop various complications of menopause, and some of them will have surgeries like hysterectomies. And then later in life, they will be subjected to osteoporosis, cardiovascular diseases, cognitive and physical functional defects like dementia or fractures, and even cancers like breast cancers. So we can see that a woman can have multiple issues depending on their age. So we adopt a view which is called the life course framework. That means we look at the problems a woman can have during different stages of their life. This shows you some of the things, some of the health issues they will face, and some of the interventions they will use during their lifespan. Now in the beginning, they will have maternal and fetal screening in the pregnancy. Then after delivery, newborn screening for thyroid profile in this country, in other countries for other rare metabolic diseases like phenylketonuria and other storage diseases, they get screened. And then in childhood they get vaccinations, and then they will start schooling, and sexual health education will be one area. So majority of the population, this is the percentage of the population who will utilize these facilities, utilize them. And then when they reach around 12 years, they'll get the HPV vaccination. Even in our country, we are now giving this. On top of that, we have rubella vaccination as well. And then in certain countries, like in Netherlands and Scandinavian countries, they get chlamydia screening, because by the time these people are active sexually and they get infected with STDs, so they get chlamydia screening. And then they come into the reproductive age. There they will have sexual health facilities, contraceptive facilities, cervical cancer screening facilities from about 19-20 years until about 45-50. And during a pregnancy, they get preconceptional care, antenatal care, and some of them who are not fertile will get assisted conception, fertility treatments. And then when they reach menopause, another set of activities from the health service will come in. So as a doctor, you should have some idea what are the things I should do to a particular woman, say somebody who is in their mid-20s. Mainly our focus should be on preconceptional care and contraception. But when you are handling them, you need to think whether they have got their HPV screening, whether their vaccinations are in order, and other things which should have had happened need to be completed. So you need to have some awareness. And then after menopause, chronic diseases, diabetes, hypertension, cancers, osteoporosis, dementia, and other things. So all these aspects need changes over the time. This is the same thing showing the health services which are involved from puberty to menopause. In the core, this is divided into two areas. Now, as a general doctor, you need to be providing these services: sexual health services, contraceptive advices, screening for chronic diseases, gynecological cancer screening like pap smears, early initial investigation of subfertility, preconceptional care, antenatal care, community gynecological services, and management of menopause. These are the core services provided by the health. And then when you need help, specialist services, pediatric adolescent gynecology, psychosexual services, reproductive services, neonatal fetal medicine, high-risk obstetrics, assisted conception services, specialist gynecological services, gynecological cancer services, family cancer genetic screening, chronic diseases screening, urogynecological. So these are the gynecological related services which are on offer throughout the female's lifespan. So as a doctor, you should know what are the things you can do and what are the things which are provided by the specialist services in our health system. And another chart which is called the stages of reproductive life, again shows the same thing, but this is mainly based on the effects of the female individual. So the endocrine changes of hormones, menstrual cycles, and how we classify. Generally, menopause is, if it is around 51 years, and then 2 years from before that up to 2 years after that is the period where we call perimenopause. During that period, you will have various abnormalities of their periods and other issues. So this is the one which causes more trouble to female health. And then we have a look at various reproductive health and lifestyle issues over the life phases. So we start with pre-reproductive female child, somebody who they will need mainly nutrition, balanced nutrition to prevent protein energy malnutrition. They need iron and iodine supplementation. They need to have highly calcium-rich food, because female children finish their calcium accumulation by around 25 years and reach their peak bone mass by that time, compared to males who will go on until their early late 30s. So, and since females are at higher risk of osteoporosis, we need to make sure female children get higher portion of calcium-rich food in their childhood. And at the same time, we need to avoid overnutrition, because childhood obesity is a big issue, which will impact their later cardiovascular health, polycystic ovary diseases, and diabetes. We need to avoid overnutrition and avoid malnutrition. Then immunization for rubella and HPV around age of 12, and then properly monitoring their growth and psychological development during the prepubertal age. And then early reproductive adolescent age group, they will have various menstrual issues, body image issues, contraception needs, unplanned pregnancies, teenage pregnancies, STDs, depression. They are prone to substance abuse and they get abused sexually as well. So if you are a doctor who is looking after a girl who is falling into this age group, these are the issues you may have to keep in the back of your mind, which might need assessment and treatment. Then they will enter peak reproductive age group. Same things, contraception, pregnancy issues, STDs, premenstrual symptoms, body image problems, weight control issues, substance abuse, then domestic violence or intimate partner violence, infertility, depression, sexual abuse. All these things are common in these. So women who fall under this category, you need to think about this. And then when they reach menopause, you will have menstrual irregularities, menopausal symptoms, body image problems, sexual function issues due to changes in the body due to menopause. Their cancer is increasing, substance abuse problems are there, depression and various domestic violence issues. And then postmenopausal, again, issues of sexual function, problems with diet and weight control, osteoporosis, cancer risk assessment and management, and various cardiovascular system defects. And then in postmenopausal, late postmenopausal age, you get urinary incontinence, urgency and other issues, pelvic organ prolapses, infections, cancer risk is fairly high now, diet problems, sexual function problems, and osteoporosis. And then you need to take into account safe exercises, because now they are having fragile bones and they might have depression due to various changes in their life. Probably the partner may be already dead, so they will have issues in handling those emotions. Substance abuse, physical abuse, even by children. And Alzheimer's risk is increasing, problems with hearing and vision, and multiple disabilities of mobility and other issues, arthritis and other diseases are restricting their life. So you need to expect these things as well as take preventive actions well in advance in their young age, so that whenever you see a patient, you need to warn them that if your lifestyle is like this, you are going to end up with these problems in later life. And then these are the common cancers of female. The breast is the commonest, and then we have ovarian, cervical, endometrial, and then bowel cancers. So these things come in and out. We'll talk about a little bit about prevention and early detection of cancers. I'll be touching mainly on breast cancer and a little bit on cervical cancers. We don't have a way of screening for ovarian cancers at the moment, and even endometrial cancers are usually possible to detect early. We don't screen them for their occurrence, but since they come with irregular bleeding, it is easier to pick them. So you need to be aware about those as well. And most of these topics will be handled and covered in your gynecological lectures. What are the things women need to know about breast cancers? The first thing is that it is the commonest cancer in females, major cause of death in females, and leading cause for premature deaths in females. It accounts for about 9% to 10% of worldwide cancers, and 6 to 8% of all cancer deaths. Fairly high disease burden. So what are the signs you should warn women about? Painless lump in the breast or armpit, persistent rash around the nipples, bleeding, unusual discharge, changes in the skin, swollen, thick and dimpled skin, puckering of skin over the break, nipple retraction or pulled into the breast. All these things, as a doctor, you should know and know how to detect, and to know how to advise women to pick those symptoms. And then you need to teach them breast self-examination, as most breast lumps are found by women themselves, and they need to do it regularly, and after some years of practice they can detect even a very small lump. So it's really helpful for you to teach women to do it. How should we do it? It should be done at least once a month, for those who are still menstruating. Best time is actually about 1 week after the period, start of each period, around day 7 to 10. If you are not having menstruation, menopausal period, then remember or mark a date, say first day or last day of every month they should do. If somebody is suspected of having a mass, then you need to do blood test, and they will get fine needle aspiration, core needle biopsies, ultrasound scanning, and sometimes mammography. Fine needle biopsy is actually using a small syringe. Under sterile condition, you aspirate a sample from the suspected tumor, and then it's analyzed by a pathologist in the lab. This is how they do it. I'm sure everyone should know how it is being done. We would have seen that in the pathology clinicals. The mammogram is a X-ray. It's a soft low-dose X-ray. After compressing the breast between two plates, it may be a bit uncomfortable, but it's only for a few minutes. It measures the size and spreads of cancers, and you can see any changes in the breast. So they need to do it repeatedly. There are no agreement on when it should be started, generally after about 45 years of age. If the family history is there, you can start even it after 35 years. And then this is how it is being done. The women has to keep their breast between these plates, the X-ray plate and the plastic plate, to compress and this is a normal one, and this is an abnormal breast. So this is probably a malignancy. You can see the scarring around that tissue. And most of the time it needs interpretation by a radiologist. So after that, sometimes we do biopsy, true cut biopsies under local anesthesia, and again do a histological assessment. In certain countries, instead of self-examination, they recommend that women get annual breast examination by a doctor, clinical breast examination. They say that increases the rate of detection. It depends. If women can be trained, that itself gives you a better outcome. Treatments are multiple. Usually after diagnosis, you need to undergo a counseling session, and then that will help you to understand the treatment and cope with it, because it's a very intensive treatment with surgery, mastectomy or breast conservation surgery or reconstruction, radiotherapies, chemotherapies, and various hormonal manipulation throughout the rest of their life. So as a doctor, you might encounter patients who are having surgery or who are after surgery and being on follow-up, and that will affect their other functions. Say somebody who is on long-term hormonal suppression of estrogen will have issues with osteoporosis. So you need to know how to handle their osteoporosis and treat it. And you need to know what they can do to reduce the breast cancer incidence. the first thing would be to start breast self-examination and do it regularly. Fatty stuff, food stuff, especially with animal fat, should be avoided. Increasing the vegetable, fruits and whole grains and fiber in diet helps against breast cancers as well as other cancers like colonic cancers. Adequate exercise is one, and maintaining an ideal body weight will not only prevent cancers but help in other aspects of their life as well. So these are the things as a doctor you should pass down to your patients in your health messages. And if somebody has a close family members with breast cancers, they should start doing mammograms early, as well as if the family history is suggestive, if it is possible and affordable, they can do breast cancer screening, gene screening. So BRCA1 and 2 screening are available in Sri Lanka. It costs about 25,000 rupees, but still fully worth for all the members in the family, female members in the family, to have those tests. Because it's not only breast cancer, colonic cancers, stomach cancers are all linked to these genes. So even if you don't have one, you will end up with the other one. This is how you do it. Ask them to stand in front of a mirror, feel for any changes while lying down, and then check the nipples for bleeding or discharges, and feel any lumps under the armpit, and do the same thing for the other breast. So those are the things as a doctor you need to know as basics, and in your surgical lectures you will be taught more about breast cancers and their treatments. I'm not going to touch those things. And cervical cancer screening is another cancer which we offer for well women clinics in well women services. We advise at least 5 yearly screening after 30 years in Sri Lanka, or at least once every 10 years screening with pap smear. If 2 previous smears are negative, after 65 years we do not offer any screening. In other countries, these screenings are done every 3 years because that increases the pickup rate of cancer. And if some pap smears are abnormal, they get a repeat smear and then refer to a colposcopy service for biopsy. And now pap smears are moving out. Instead, HPV or human papillomavirus, which is the causative agent for cervical cancer, is screened by DNA of the papillomavirus rather than the pap smear, which detects only the cervical changes. And one thing you need to remember is that the cervical transformation zone, where the sampling is done, changes over age. Before puberty, your transformation zone is inside the cervix, which is the squamocolumnar junction. And after at puberty, it comes out, and you will, because the cervix everts. And this is the period where they are more vulnerable for infection by HPV virus. And then after puberty, this exposed area of the columnar epithelium undergoes squamous transformation, and new squamocolumnar junctions is at the area in the outer part of the cervix. This is the area where the cancers start happening and virus gets implanted. So when you are taking samples, you need to identify the transformation zone and take the biopsy. If you follow the proper pap smear technique, it will not be a big issue. But remember, after menopause, your transformation zone is not outside, it is inside. So you need to use cyto brush or cyto broom to get the sample. You will be shown these things in your cervical cancer lectures and in your practicals in the ward, in the clinics. This is how we do pap smear. These are the things. This is the cervical brush. This is the spatula, spatula. This end is for walls or small cervices. This is for taking samples from the endocervical canal. This is the slide, and then if it is abnormal, we send them for colposcopy. You can see the colposcope at Pelvic Hospital. This is how you take the sample. This flat end is actually for taking samples from the ward, and you can use spatula. And in postmenopausal age, mainly you need to use brush, cyto brush. And it is, there's another thing called broom, which is a kind of a broom-like thing with bristles. We can use that to take a sample from the cervix, and mainly it is used for HPV screening. And this is how you apply the sample taken from the cervix in this direction. Don't move the spatula over this thing on both directions. You need to spread it onto one direction. This is also incorrect. And then they are getting interpreted, and then you need to know how to handle them. You will be taught more about these things in your cervical cancer lecture. And then we have endometrial cancers. Again, the peak incidence is between 45 to 55. Any woman who is in around that age group coming with any bleeding or discharge, it doesn't have to be postmenopausal. Anybody in the perimenopausal age group having irregular heavy bleeding, again, needs follow-up. Then the next thing would be to see their cervical or the endometrial thickness by a transvaginal scan, and if it is globally thickened, you can take a pupil sample to take a sample without anesthesia, or if it is focally thickening of areas more than 3 to 5 millimeters in size, you take a sample with hysteroscopy under direct vision. So those samples are analyzed, and then we take action according to the histology. Then we encounter post-reproductive life issues, mainly menopause. So you will be taught most of these things in your lectures on menopause. Basically, menopause changes the whole women, from the mood, skin, various vascular symptoms like hot flushes and night sweats. Their hair distribution changes, facial hair increases, scalp and pubic hair decreases, even axillary hair decreases. Heart diseases start appearing, breast shrinks, bone losses, fractures are common, and then vaginal dryness, incontinence, infections start happening. Most of these symptoms start even before the actual last period, which is around 51 years. Happen about 2-3 years before that, the women will start seeing, and then vaginal discomfort will follow, bladder problems will follow, and then around 6 years you will end up with having heart diseases and osteoporosis. So you can see perimenopausal period starts well before real menopause, and once they are after menopausal symptoms, which is 1 year without menstruation, we consider them as postmenopausal. It affects skeletal health, CNS health, cardiovascular health, skin, and genitourinary systems. Long term, once they reach menopause, bigger problems are the fractures of the hip and the vertebrae, cardiovascular diseases, coronary diseases, strokes, and prolapses, immobility, muscle weaknesses, osteopenia, sarcopenia, and skin changes. And then all these problems increases in their significance as the time goes. These are the things which will happen to your body over the time period, and fractures. Immediately after menopause, there is a rapid bone loss. So this needs to be reduced as much as possible. So anybody who is in around 50 years, you need to advise of increase in calcium intake, exercises, as well as screen for calcium bone density. We do that by a special X-ray called DEXA scan. It's a soft X-ray to detect the calcium. So you need these things. You have to treat symptoms of various diseases, treat hot flushes, genital symptoms, heart diseases, and osteoporosis. At the same time, you need to be more proactive. Start these things in their early 40s, promote health, feeling of wellness, awareness, change their diet, exercises, target for symptoms relief, and stress management and education and long-term preventive therapy should be started well before menopause. So as a doctor, when you see somebody who is coming to you in their late 30s, early 40s, you need to warn. And each time you should pass 1 or 2 messages about menopause and its effects on their health. Whatever possible, you need to get them to change. Little by little, these messages will sink and that will have a positive impact. So you need to be aware that a woman who is coming to you for some other reason, maybe a respiratory infection, maybe some issues with their children, still you need to attend. This is a DEXA scan report of the spine. You can see L1 to 4 vertebrae had been scanned and the density has been assessed. So the report comes like this. It has T score and Z score. The interpretation of these you will be taught in your medicine lectures, but basically this is density compared to somebody who is at their peak age, which is around 25 years, and this is the Z score based on their own age, the patient's own age, and this assess. So this is a woman who is around 60 years of age, having the bone density in the red zone, which is the osteoporotic zone. So that patient is having osteoporosis, so you can't prevent it now, you need to start treating. So best method is to send them across to a endocrinologist services. They will start treating. At the same time, you need to warn them about healthy posture and preventing fractures, and if a fracture happens, to seek help with orthopedic services, because it's now very easy to fix a fractured hip or neck of femur with orthopedic prosthesis. But fractures in the spine are a bit difficult, and usually spinal fractures changes your whole life's outcome. You will be confined to a wheelchair and your mobility will be very low and will be catastrophic with regard to your health. Urinary incontinence and pelvic organ prolapses are another area. Again, you will be taught in detail in gynae lectures, and prevention has to happen well before the menopausal age, mainly during the reproductive age. Every woman who is leaving your postnatal ward should be educated about pelvic floor exercises. There are 2 types of pelvic floor exercises. You need to know how to do them. They are called slow twitch and fast twitch. You start with slow twitches and then finish with fast. Basically, you identify the muscles around your back passage and close them, and without contracting the buttock muscles, and then identify the muscles around the vagina and then close them and pull them up, like when you are trying to stop the flow of urine. Hold it for 5 seconds, count up to 5. You don't need to change your breathing and do it relaxed, and repeat about 5 times, go up to 5 times. And then move on to, after finishing those 5, you need to move to same muscles as before and then hold for 1 second and then relax. This you need to repeat for 5 to 10 times or until you feel that the muscles are tired. You need to avoid tightening the lower abdominal muscles as well as the buttock muscles. So you can even feel for your buttocks and see whether you are tightening them. And do it properly, and that will, over the time, you need to do it regularly for about 2-3 months, then you will see the effect on it. And if you do it in time, so in young age, the risk of post-menopausal incontinence, so stress incontinence, pelvic organ prolapses can be reduced. It's much better to invest on these early rather than going for surgery and other things later in life. But you need to make sure that since pelvic floor muscles are muscles which can get tired easily, they are skeletal muscles, so they can get tired easily. You need to develop concentration and do it gradually and in increasing frequency. Idea is to do it without squeezing the buttocks, without holding, without putting knees together, without lifting shoulders, eyebrows or toes. So all these are indicators that you are not doing it properly. So when you are teaching patients, teach them these as well. And then in our country, the last bit on the lecture is how we do it in our country. We have from 1996 started a Well Women Clinic in all MOH areas. In that we offer a general physical examination, blood pressure screening for hypertension, diabetes screening, breast examination, breast malignancies, and visual examination of cervix, as well as pap smears when it is available. And sometimes you might provide family planning services, as well as health education on menopause, prevention of osteoporosis, and STD/AIDS, as well as advice on nutrition and maintaining a healthy lifestyle. All these things are done in the Well Women Clinic. This is how you should organize a Well Women Clinic: registration, urine examination by the PHM, health education by MOH or PHNS, history taking by PHM, and an examination by the MO, and then finally giving the information as well as plan for the next visit. So these are the things done in your clinic. As a doctor, you should have some idea how it is done. You don't really need to have only clinics in the MOH areas. Any hospital outpatient department can do these things. Right. If there are any questions, you can ask them in the comments, and most of these topics will be covered in one part or the other in your course in medicine as well as in gynecology. But this is the lecture which will summarize them and put them in one lecture, so that you should have some bearing on what the things you are learning. Thank you.